Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, friends and colleagues. I would like to welcome you all to tonight's webinars. It's the Cardiometabolic Academy series. My name is Fathia Al-Awadi, and I will be moderating tonight's webinar. I was supposed to moderate the session with Dr. Wael Mahimid. Unfortunately, because of emergency, he will not be with us, and he apologized. And we hope all goes smooth with him, and he join us on a future meeting. I just wanted to introduce the webinar to you. This is a joint efforts between the Emirates Cardiology Society and the Emirates Diabetes Endocrine Society, which has been, we were been working on this for several months. And I take the opportunity to thank Dr. Wael Mahimid as well as Dr. Hani Sabur for their great effort that they had put over several months in order to bring the 4 series of this webinar. Today we'll have the first part of it, and I want you to log, block your calendar for the future 3 webinar that we will announce for the date, at the end of this tonight sessions. We have a great speaker that they are well known to us in this in our region as well as international, and I'm sure that you're going to enjoy today's program. The program is live on the YouTube channel, and also is going to be available on demand on the EDS Institute website, which is the www.edsinstitute.org. So you can always log in and you hear it at any time. If you have any questions for the session, kindly just type your question into the Q&A box, and we will be taking the Q&A after the first 2 talk. Also, if you have any queries related to any thing of tonight's webinar, you can always, send your request or your queries on the WhatsApp on the available phone number. And this is a CME accredited program, to CME accredited by the MOH, Ministry of Health and Prevention. So now, without further delay, I would like to introduce my friend, Dr. Mohammed Hassanin, who's well known to you. He's a consultant endocrinologist at Dubai Hospital, Dubai Health Authority, and he's a Deputy Director of Postgraduate Diabetes Education at Cardiff University, and he's the Chair of DAR Alliance. Mohammed will be talking about diabetes and cardiovascular disease in UAE, alarming number. Mohammed, the mic is yours. Kindly unmute yourself and share your screen.
Assalamu alaikum. Thank you very much, Fathia. It's a great pleasure to be a part of this exciting program, this interesting collaboration between Emirates Society for Diabetes and Endocrinology and the Cardiac Society of UAE. Great pleasure to be with you all, and hopefully, inshallah, that you will have an enjoyable meeting. So my task for tonight, for the first part, is to address diabetes and cardiovascular disease in UAE. And I would like really to focus on some of the numbers that we have in the country as well as in the region. So when you start thinking of why should we be concerned about diabetes and cardiovascular disease? Because unfortunately, in people with diabetes, whether they are men or women, the data show to us that they can lose about 6 years of their life because of the impact of diabetes on their vascular health and their vascular disease in general. So it's important that we have these types of academic activities so that we're all aware of what needs to be done. When you look into long time ago, nearly 18 years ago, this publication about silent ischemia in people with diabetes, a condition that must be heard. That publication was there in the American College Cardiology journal 18 years ago. They looked into people who, 1,900 persons, asymptomatic with type 2 diabetes, and their mean age was 52 years. They were under 60 years of age. And they went for stress testing, and then coronary angiography was performed in those with myocardial perfusion defects. It was quite interesting to see that 60% had abnormal stress test and 65% had significant coronary disease on angiography. They thought that autonomic dysfunction was a key factor for all of these problems. So it's important for all of us to know our patients. We understand the disease very well, but what is missing is better understanding of our local patients. The patients that we see every day, whether from a national background, an Arab background, an Asian background, or whatever background. Myself and my dear friend, the chair of our session tonight, Dr. Fathiya, we published recently in the Dubai Diabetes and Endocrine Journal the prevalence of diabetes and pre-diabetes in Dubai in 2014 and 2017. And as you can see here, unfortunately, we have high rates of diabetes and pre-diabetes. When you look into the figures here of diabetes, we are talking about 15% overall, and pre-diabetes equivalent number. So over 30% of Dubai population have either diabetes or pre-diabetes. When we looked again into these issues for 2019, the Dubai Health Authority survey was done every 5 years. So 2014 we just seen, and now the 2019. The ratio is more or less the same. This is the data of diabetes, 19% in Emiratis, 13% overall, 13.7, and expat 12.4. So marginally lower than the data of 2014, 2017, but I think we should not really read too much into is it lower or not. I think it's more or less very identical data. Now, we know that cardiovascular disease is a problem of older age group. And unfortunately, diabetes is the same, as you can see here clearly. In those who are 60 plus in Dubai, they have 43% prevalence of diabetes, compared to 8.5% in those who are in their mid-20s to mid-40s. So clearly age matters when it comes to prevalence of diabetes, and we all know that also age matters when it comes to cardiovascular disease. But another important point of understanding our population is to try to understand their lifestyle. And in this paper that it was published 2019 by colleagues from Dubai Health Authority, as well as Dr. Fathiya and myself, you can clearly see that the vast majority of our patients do not do moderate intensity physical activity on a daily basis. Those who do it on a daily basis, only 17%. When you look into vigorous physical activity, which wasn't really so vigorous, it was only 10 minutes continuously of running or playing football for 10 minutes. Only 5% were doing this on a regular basis. So clearly, we do not exercise very much. Now, it's not just us here in UAE that we're not exercising very much. When we look into data extrapolated from a epidemiological study for the MENA region, now you find that inactivity is 22%, low activity is 41%, high activity is 4.4%. So it is not really about just one country, it's about the full region that has very low level of activity. If we look into the prevalence of diabetes in other neighboring countries that constitute partially a sizable percent of population, so people from Alexandria and Egypt, I took part in this big study of nearly 10,000 persons, and the situation is no better. Here is the overall prevalence of diabetes. The total is 16.8. Men is 12.7, women is 19%. So, and obviously, as you can see here, the prevalence in those who are above 60, as you can see here, it is also as a total is just under 40%, 37%. So slightly lower than what we've seen in UAE in age-wise, but overall is not terribly different. Now, if I were to look, this is more or less the same, into Pakistan data, then it's very much even higher. Prevalence of overall diabetes that is published by our good friends, Professor Abdul Basit, from a survey they did in 2017, 26.3% prevalence of diabetes and 14% pre-diabetes. So 1 in 4 in Pakistan is either diabetic or pre-diabetic. So that begs a question that I would like to share with you. It's not a polling question, it's just a question that we all need to think of. Do the majority of people with type 2 diabetes has cardiovascular disease? And let's look into the data. The extrapolation of the data from the cardiovascular outcome trials that was done at 6 studies for GLP-1s. And when you look into the different trials and you look into the characteristics, and if you try to apply them to the general population of diabetes, it varies according to the design of the study from as low as 8% to as high as 22%. If you were to apply the same to the SGL2 cardiovascular outcome trials, you will also more or less see the same pattern. So here is eligibility based on established CVD, the light pink, and the darker pink is based on cardiovascular risk. So those with established cardiovascular disease were as low as 6 to 7% from these trials. But a sizable proportion of the patients have cardiovascular risk pattern. This is the latest data that I share with you. It is published a few months back, a large survey of type 2 diabetes of 5,865 persons. It was meant to be a Ramadan-based study, but nevertheless, we were studying the characteristics of the patients. And we dissected the data based on below 65 years of age or above 65 years of age. It doesn't matter, look into the overall. The mean age is 55 and mean duration of diabetes is 10. What is the prevalence of coronary artery disease or stroke? 10.8%, let's say 11%, because probably some of those with diabetic foot disease have peripheral arterial disease. Now I've highlighted the retinopathy here because retinopathy is considered, as well as nephropathy, as end organ disease, which put the patient into an equivalent risk to those with established cardiovascular disease. And here, 10% have nephropathy and 14% nearly have retinopathy. So this is from 20 different countries, going from Morocco until Malaysia. So it is important for all of us to remember the risks that our patients have. When we engaged with the colleagues from the Middle East to look into the cardiovascular risk in Arab countries, based on all the data that was available at the time, you will see here that diabetes estimation was 18.9%, obesity about 40, obesity, not overweight, just the obesity. Here it is 32%, hypertension is 27.5%. So clearly our patients have plenty of risks. I personally looked into this and I published this data in 2003 into the IDF conference in Paris. Secondary care patients have lots of cardiovascular or macrovascular disease. At the time, I was running a clinic for macrovascular disease and diabetes, and 47% of our total diabetes population were of 47 years. But you need to look also into the mean age. The mean age of patients with diabetes in Western society is a lot higher, that is 65.5, which is different than our age. Then if we now shown that the patient do not have high rates of established cardiovascular disease, let's ask the opposite question. Do the majority of people with cardiovascular disease have type 2 diabetes? And I would like to share with you a study that we did in Dubai Hospital. And here is the names of the authors, myself and Dr. Fathia and Dr. Hussein Zaki and Dr. Fawzia Rashid and Dr. Noha Yassin and Dr. Saima Mirza. And we looked into admission to the cardiovascular ward over 2 consecutive years. And we managed to find data for 320 patients. Now, 46% of the total admissions to the cardiac ward not with arrhythmia, but with an ischemic heart disease or heart failure were people with type 2 diabetes. But when you look into those with established cardiovascular disease, previous history of cardiovascular disease, that goes up to 2/3 of the population in the cardiac ward. And interestingly, heart failure was double the rate in non-diabetics. 30% patients with the admission to the Dubai cardiac unit were with diagnosed as heart failure if they had diabetes, versus only 16% if they do not have diabetes. So clearly, heart failure is another important point that goes missing. Does this matter? Yes, it does. Because as you can see, the diabetic person stays in the hospital ward over 2 extra days. The average length of admission for the non-diabetic is 5 days, for the diabetic is 7 days. And that really is quite important for those with established cardiovascular disease. For those without established cardiovascular disease, the increase is 1.3 days, from 5.1 to 6.4. And surprisingly, perhaps because the data was 2018 and 2019, where SGL2 and GLP-1s were just about with the knowledge about them, but about 3% to 3.8% of the admission patients with diabetes were already on any of these 2 important drugs that have evidence of cardiovascular impact. But one interesting point is the huge disproportion of males to females in our cohort. Now, we know in Dubai population and in UAE population, we have far much more people from a male gender rather than female gender. That is related to employment forces and needs. But having said that, as you can see here, we are talking about very high proportion of 73% of males with diabetes are admitted versus 27% only of females. And you need to ask yourself why. And why is perhaps answered in the data from Abu Dhabi, from Waqaya data that looked into the whole Waqaya population. Waqaya is an insurance program, and they looked into 55,000 persons who took that insurance and looked into the cardiovascular risk factors for them. And as you can see, male in blue and females in red, men have much more prevalence of central obesity, of hypertension, of dyslipidemia, and of smoking compared to women. So it's really important that we try to understand why certain gender have the problem, because we need to focus on this. Now, the data that I've shown you from Dubai have been more or less echoed in previous publications from the Gulf region. When we look into the data of coronary heart disease in the Middle East and North Africa, the current state of affairs that was published by our co-chair, Dr. Wael Mohammed, we hope that his emergency or his the reason for him not being with us tonight, hopefully, inshallah, it will be fixed. But what they've shown is that the Middle East patients who are admitted with coronary artery disease, whether in the Gulf race data or in the inter-heart data, are much younger than their counterpart in Western society. And that's really very important for all of us to remember. Again, the same, here is the data of the inter-heart. And as you can see here, the mean age was 51.2 years, which is quite different than the Western society data. The association of the acute myocardial infarction in the inter-heart data is very much related to our lifestyle. A very important factor is smoking. And I'm particularly concerned about the vogue of shisha smoking among men and women. In the past, it used to be limited, but now it's becoming more of a fashion. So, of course, we have the classic issues of hypertension, diabetes, and abdominal obesity, but shisha smoking is really an important factor that perhaps we need to tackle. It was a bless during COVID time when shisha was not allowed. Perhaps this is something for future public health issues. Again, when you look into the Gulf race data, 40% of the admission is people with diabetes. So not terribly far from the data that I've shown you from Dubai, where I've shown you that over 40% of the admissions to the cardiac unit in Dubai are people with previous history of diabetes. So clearly, there is an issue about lifestyle, weight loss, exercise, and of course, glycemic control. I'm not going to address glycemic control. I want you to think of the lifestyle, weight loss and exercise. And I've shown you the data that unfortunately is showing to us that we have very sedentary lifestyle. So consequently, because of all this, when we sat together 18 months ago to look into the Emirates Society Type 2 Diabetes Guidelines, we very much took into heart the latest recommendations and also the age factor that we have here. So we developed this beautiful algorithm that looks into 4 levels of risk: very high, high, moderate, or low. It is dependent on the presence of the type 2 diabetes with cardiovascular disease or with target organ damage. And I remind you, the target organ damage that we're talking about here is nephropathy, retinopathy, or left ventricular hypertrophy. Of course, a person who has any type of cardiovascular disease is already established. But the other extra factors that you need to think of your patients is moderate retinopathy, or indeed nephropathy, or if they do an ECG and they show signs of left ventricular hypertrophy. In the absence of this, then you start thinking of the age of the patient above 50 or below 50, the duration of diabetes below 10 years or above 10 years, and then the number of cardiovascular risk factors, which include hypertension, dyslipidemia, smoking, and obesity, not overweight. So this is really quite important because this is the basis of how we classify and dissect the data to diagnose our patients. So with the new information that we have, the question for all of us, how should we address our patient? Should we focus on cardiovascular, standard cardiovascular risk, stopping smoking, treating blood pressure, lipids, or should we treat the glycemic control, or we should address both? And I would like to share with you the data of 2 important studies. The STENO trial, which is really very important. It's not a huge trial. It's only 160 patients, but they addressed every single risk factor. And over 8 years, they managed to reduce the cardiovascular risk by 50% in their patients by addressing everything. And again, here, when we look into our own data from Dubai, how well are we treating our patients? This is data that we presented at the Emirates Society meeting, and this is from 2020, from last year, during COVID time. Again, we have a high preponderance of females as diabetes. Having said that, it doesn't reflect on admissions. Of course, the vast majority of our patients are national, followed by other Arabs, and some from GCC. Then there is the Asian community. BMI is very much on the high for people with diabetes. Those with normal BMI are only 25, are only quite low, less than 20%. The vast majority here are people with overweight, obese, or morbidly obese. So clearly something needs to be done. And if we to look into the HbA1c, the good thing is the vast majority of our patients have a well-controlled HbA1c. Below 7 is 54%. Now, if you were to go to say, well, between 7 and 8 is not too bad, at least according to some of the cardiovascular studies, that takes us to another 21%. So about a quarter of our patients have poor glycemic control that needs significantly much more improvement. Blood pressure, 70% of our patients have a diastolic of below 80, and only 23% of 30% have a high diastolic blood pressure. Systolic blood pressure also seems to be below 140 for roughly 3/4 of the patients, but higher in about another quarter of above 140, which indicates there is room for improvement. If we move to LDL, you would see that, or LDL and HDL, the HDL obviously is the protective cholesterol. We want this to be in the vast majority of our patients, and luckily that's the case. The vast majority have an HDL above 45, which is quite good. Perhaps some of these between 40 to 45 are men, which also is normal. So clearly the HDL is not a major problem, but there is room for improvement for those with LDL, because unfortunately the data is not sophisticated enough to tell us what is the LDL of those of high risk versus moderate risk or low risk. But in general, if I were to say that I would like the HDL of my patients to be below 100, then that is over 50% of our population, 53%. So clearly we need to address all of these risk factors together: glycemic control, blood pressure, systolic blood pressure. If we do that, based on the data published from the Swedish Register, which is a massive register of over 1.3 million persons, what they did in this beautiful study, they looked into 271,000 persons with type 2 diabetes, and they tried to address all of their risk factors. And they looked into important parameters, into death as well as MIs and stroke. And the beauty of the data is showing is, if you address these 5 risk factors and get them to be well controlled, the death as well as the myocardial infarction and strokes of people with diabetes will be equivalent to that of the general population. So clearly we need to try to understand the situation. This is my take-home message. We have quite prevalent risk factors in people with type 2 diabetes in our community. In patients with type 2 diabetes, we need to choose the drugs that have the evidence for cardiovascular disease or chronic kidney disease improvement. We need to try to stratify our patients in the early stages, and we need to look into measures that will make our patients adhere to the treatment. But it's not just about glycemic parameters. It is definitely, we need to address all the cardiovascular risk factors together. And we need to do that now, because we are far too late. Working in harmony like an orchestra, addressing the diabetes medication, the aspirin, the statins, and the antihypertensive will hopefully lead to a far much better outcome. And finally, I'll leave you with photos of my beautiful city, Alexandria. Thank you all, and I look forward to the following session of today's meeting.
Thank you very much, Mohammed, for this excellent presentation as usual. And before I just proceed to the next speaker, I just want to remind you that this is one of our 4 webinars that we are planning to do, which is the Cardiometabolic Academy in association with the Emirates Cardiology Society. And also I would like to take this opportunity to also thank our sponsor for their unrestricted grant, Novo Nordisk, to support us to conduct conduct these activities. And if you have also any questions, I can see that there's some questions in the Q&A. Please type your question there, and we will be taking these questions at the end of the two talks. Now, it gives me great pleasure to introduce a friend, Dr. Hani Sabur, who's again well known to all of you. Dr. Hani is a consultant cardiologist and electrophysiologist at Cleveland Clinic, Abu Dhabi. He had established a comprehensive pulmonary hypertension center and the PH registry at SKMC, as well as leading the Sahha PH guideline writing team to complete the Sahha clinical practical guideline in pulmonary hypertension. So Dr. Hani will be presenting today the cardiometabolic care, a new era of collaborative medicine. And Dr. Hani, please just unmute yourself and share your slide.
Thank you. Thank you very much, Dr. Fathiya. Really, it's a great privilege to be part of this really important and clinically and demographically and academically very, very critical collaboration. I think, working together, and I think we've done this almost over the last 6 months, we come up with a lot of important insights that's going to have a lot of impact on the community and our colleagues as well. So this is the title, as you very nicely pointed out, the Cardiometabolic Medicine, first of all, defining the global pandemic and the urgent need for collaborative care. And I think this is really one of the foundations as we start today with this really important collaboration. So the current care model in diabetes, cardiology, internal medicine is that you have the patient goes to primary care, then is referred to cardiology, and then is referred to the endocrinologist, and then also has these other subspecialties that are important, but they come sort of at the end of the spectrum, liver disease, sleep medicine, erectile dysfunction, all of these things. So it's a sequential process, and it really depends on somebody pulling the trigger and moving to the next step. So what we wanted to discuss, and I think the epidemiology of cardiometabolic disease was in the Middle East and the region was delivered in an outstanding way by Dr. Hassanein. The economic impact is a very significant issue, and if we leave this burden unchecked, really, it will really bring our healthcare systems to a staggering halt. And of course, we're going to look at the parallel conditions that are related to cardiometabolic disease as a pandemic. So we had a lot of discussions about this, and I think it became immediately relevant that the reason why we have to have this kind of discussion and subsequently build cardiometabolic clinics and cardiometabolic care is that cardiometabolic diseases are skyrocketing. So these incidence and prevalence data that are being shown and consistently are being shown are increasing day by day. In terms of economic burden on the healthcare system, it is tremendous. And also on the individual patient, if they have a complication of diabetes or cardiac disease, it's a tremendous burden as well, especially if they have something really disabling like stroke or a heart attack. There's a tremendous amount of evidence-based medicine, but it is seldom prescribed. That means we really have to move the needle forward and give the patients the best cardiovascular, metabolic, diabetes protection that we can probably offer. And as shown by the symphony that Professor Hassanein showed at the end of his talk. And finally, it is unfortunate, but because of the way that everybody's practicing in silos, we have fractured care, and therefore we have to have multidisciplinary teams to coordinate and deliver care overall. So just very briefly, we have a typical patient. I'm sure you've seen this kind of patient 100 times in your clinic. A 52-year-old man comes for evaluation of erectile dysfunction and daytime sleepiness. He has a family history of obesity, diabetes, and coronary artery disease. He drinks 2 sodas a day, mostly pre-prepared foods, sedentary lifestyle. He's overweight, all central obesity, blood pressure mild at 135/85. He has a elevated fasting blood glucose, nothing tremendous, elevated liver functions, elevated CRP, moderately elevated LDL, low HDL and high triglyceride, and 1+ protein and fatty liver. So this is a cardiometabolic patient in every way, shape, and form. But underneath the surface of his mild lab findings, this patient has significant cardiac and vascular complications that are likely to cut this patient's life short by at least 6 to 10 years. That was shown very nicely by Dr. Hassanein's initial presentation. So what is the problem? The problem is that people have evolved in a negative way. And I mean this in a very socioeconomic manner. we have actually become very sedentary, very obese. We overuse very high carb, very fat medications. We do very little exercise. And in fact, the hunter-gatherer, the healthy LDL, the healthy food, we don't have that. We don't actually do any kind of exercise. And as was very nicely shown, it's really amazing if you find a patient who does exercise regularly. So over a few thousand years, we've actually evolved into this very bad syndrome of metabolic disorders with insulin resistance and all of its associated diseases, largely because of caloric intake, refined carbohydrates, inactivity, and an explosion of abdominal obesity with insulin resistance. So we don't have to explain the benefits of exercise, but I think the point about the metabolic syndrome is that it's a way to explain to patients and to remember, as we see patients in the clinic, that it is an association of really bad things, right? So the central obesity is a surrogate for inflammation, elevated A1C, low HDL, and this confers a very high short-term risk of cardiovascular disease, very high risk of diabetes, and therefore you multiply those two together and you get a very high lifetime risk of cardiovascular disease, well beyond traditional risk factors would be expected in small amounts. And of course, this is also associated with sleep apnea, erectile dysfunction, and fatty liver. Now, one of the important things to realize is that almost all of these risk factors in patients with a first myocardial infarction, young patients in the United States in particular, are modifiable. So prior to the first acute MI, we could have addressed diabetes, we could have addressed hypertension, we could have addressed dyslipidemia, we could have prevented obesity from getting worse, and we could have modified smoking. So 90% of these risk factors are modifiable before the first event actually happens. And that's kind of a shame because really there's a lot of things we could have done in primary care in an organized fashion. So cardiometabolic diseases arise from physical inactivity, poor diet, obesity, overt diabetes, hypertension, atherogenic dyslipidemia, and subclinical inflammation. Now, there's a lot of data from worldwide. I'm going to share with you some very interesting data that was published last year. So physical activity, again, this is not specific to our region. In fact, even in the United States, where there's sort of a lot of interest and focus on health, the amount of people who get enough physical activity essentially are only 24%. It's better in the urban environments, better in the last few years, still quite terrible if you think about it. So we're not alone, and this is not a specific feature of living in the Middle East. Daily physical activity is associated with reduction of all-cause mortality. Patients who exercise vigorously, actually about 10 to 20 minutes per day, have a 40 to 50% reduction of all-cause mortality. Those people who just walk have a 20% reduction of all-cause mortality, but they have to do it for at least 30 to 40 minutes per day. So no activity at all is almost a lethal complication. What about sitting time and risk of mortality? Can you believe this is an actual clinical study? Remarkable. Patients who have no physical activity whatsoever, nothing, no walking, no physical activity, you sit more than 8 hours a day, have an 80% increase in their hazard ratio of death compared to patients who do even a little bit of walking per week. So I think we got to get out of our chairs and start walking. This is a really serious thing. Healthy diet, United States, again, very limited healthy diet. In fact, the majority of patients are now junk food, very high caloric intake, very high carbs, and it doesn't really matter what ethnic group you talk about. This is really sobering data, and it's really very recent and was published actually in 2020 in the AHA. Now, what is the incidence of obesity? Are you surprised? It's increasing. What about severe obesity? Severe obesity, that is the one that is directly and rapidly associated with cardiovascular and metabolic events. It's increasing by almost 50% from 4.7 to 9.2 over the last decade. And obesity in general is basically approaching almost a doubling point if we get to 2030. So really, what do we expect is going to happen? The prevalence of obesity by 2030 will encompass almost the entire United States And severe obesity is going to be the pattern in almost a third of the United States, especially in the lower states over here where metabolic syndrome is rampant. So what do we think is gonna impact from that? So there is really this idea that obesity is related to cardiovascular disease. This is a fact. Patients with obesity, even if they don't have dyslipidemia, hypertension, and no overt diabetes, have a 49% increased risk of coronary heart disease, 7% cerebrovascular disease, and 96% increased risk of congestive heart failure, 96%. And that's the HFpEF phenotype that we've talked about before. The increase in diabetes is also parallel to the increase in obesity. So there's almost 100% increase in obesity over the last 20 years and a 50% increase in overt diabetes, again, over the same period of time. And with that, of course, you realize that if you have undiagnosed diabetes, which in fact, remarkably, is still seen in the United States, as well as diagnosed and total diabetes, you see that the number over the last 20 years has gone from approximately 8% to 12% and continues to rise unabated. If you look at this heat map, it's looking pretty dark and pretty miserable right now. Overall, globally, we know that the amount of diabetes year on year is increasing. And in fact, the greatest increase is predicted to be in Africa and the Middle East. This is not a good thing to be number one in. And in fact, as this increases, of course, our likelihood of coronary artery disease, heart failure, stroke, myocardial infarction, and peripheral artery disease is going to be really a remarkable difference. So why is this also a problem? Because during diabetes, we have other risk factors. So you're multiplying the effect, not just adding. Most of the patients with diabetes have an LDL of more than 100 in spite of using a statin. Most of the patients are hypertensive or antihypertensive medication use, 71%. Most of diabetic patients are obese or at least overweight. So it's a clustering of all of the bad things that we need to avoid. Hypertension, of course, is also growing, and you see the prevalence of hypertension is growing tremendously, and this is also the recent AHA 2020 report. And what about atherogenic dyslipidemia? So this is interesting because the use of high-intensity statins and the aggressive use of the guidelines has caused the total LDL percentage and the total cholesterol to actually start declining over time because of the aggressive utilization of KPIs and evidence-based medicine and statins in the United States. And that's something I think we need to strive for. Now, what about inflammation? Now, remember, C-reactive protein is a marker of cardiovascular risk and cardiovascular inflammation. And as it is, if the level increases above 3, it increases the risk of cardiovascular events regardless of the baseline LDL. It basically doubles the risk of cardiovascular events. And the implication is if you have a patient with inflammation, with non-alcoholic fatty liver disease, which causes CRP to go up, with metabolic syndrome, those patients have a consistently higher C-reactive protein, and in top of their LDL, they really have a very, very high cardiovascular risk. And those are simple clues that we can also extract into our clinical settings. Now, I mentioned this at the beginning, and this is a really nice study that was recently presented at the EASD last year in 2020. And it's the CAPTURE study. It's a large cross-sectional study using contemporary treatment, looking at cardiovascular disease in diabetics in 13 countries. Of course, the reason for this study is that CV death is the largest cause of morbidity and mortality in patients with diabetes. There is a prevalence of CV death across the globe in other underrepresented countries was not well known. CVOTs has shown a tremendous benefit with SGLT2 and GLP-1 receptor agonists in treatment recommendations across the board. So knowing the impact of these evidence-based treatments in terms of the prevalence of cardiovascular disease in diabetic patients is very important. And the CAPTURE study looked at 13 countries on 5 continents, large cross-sectional non-interventional study for diabetic patients. First of all, to look at the CVD prevalence in the 3 countries, and also looking at differences in gender, clinical parameters, and medication use. So in this study, in fact, the Middle East was reasonably represented. Out of 9,800 patients, Turkey had 800, KSA had 883, And of course, we had patients from China, Japan, Mexico, Italy, and other countries that don't normally appear in clinical studies. In terms of the prevalence, the division was 4,000 patients in primary care, 5,000 in specialist care. The overall prevalence was about 34% in all the countries, and similar if you took diabetics from a primary care setting or a specialized setting. ASCVD, coronary artery disease prevalence, was approximately 30%, again, whether seen in specialty clinics or non-specialty clinics. So this is the background prevalence of coronary artery disease. And if you look at this study, basically dividing all the countries together, most of the prevalence is between 30 to 50%. The outlier, though, is KSA, where they only had a 18% prevalence, and this may have been due to underestimation by screening, or maybe because of the young age of the patients. But almost all the other countries were ranging between 30 to 50%. Now, the types of coronary artery disease, or CVD, are different. So we have heart failure, we have vascular disease, we have arrhythmias. Coronary artery disease by far is still the highest, followed by stable CAD and myocardial infarction, carotid and cerebrovascular disease, and heart failure. So remember that cardiovascular disease encompasses a very large spectrum of cardiovascular conditions that are seen in the diabetic patient. The mean age in these patients, whether they had or didn't have CVD, were about 64 years old. Almost all of them had 10 to 13 years of diabetes. The A1Cs were, as Dr. Hassanein showed, were moderately controlled, 7.3, and the BMIs were not terrible. Blood pressures were generally consistent. Most patients had hypertension, more in the cardiovascular disease group, and the LDLs were between 2.3 and 2.5. The GFRs were distributed. The minority actually had severe CKD. Almost all of them had some degree of CKD, however, when you looked at all of the groups together. Now, this is the unfortunate circumstance, and that is the use of cardiovascular medications in patients with CVD and diabetes was, in general, suboptimal. Statin use, only 50%. Antiplatelet therapy, only 50%. At most, and more in patients with cardiovascular disease. ARBs and ACE inhibitors in the minority, and beta blockers in about 2/3 to 1/3. So this is important because, in fact, if we want to minimize across the population, all of these numbers should be approaching 100%. 100% of diabetics should be on a statin. And if they have cardiovascular disease, you're targeting an LDL that's pretty low, around 1.4 or 55. What about glucose-lowering agents? And again, I think Dr. Hassanein showed this very nicely. The use of oral anti-hyperglycemic medications is high, 96%. But what about the disease-modifying therapies that we so well talked about in terms of the evidence? 16% SGLT2, 10% GLP-1. And this may be due to issues like cost or adoption and so on, but there's a lot of use of insulin and a lot of use of multiple oral hypoglycemics. Why are these agents, which save lives, reduce CV events, not coming into the fore and being added early on with biguanides like metformin, as is recommended in the guidelines? Remember, these are type 2 diabetic patients, and I think there's a lot of evidence to say that we can do a lot more to help them. And whether the patients had cardiovascular disease or not, this didn't seem to make a difference, even though, as the Emirates Diabetes Society showed, if you have evidence of target organ damage, including cardiovascular disease, the utilization of disease-modifying therapies is extremely important. So the ones that have a CV benefit, GLP-1 receptor agonists, or SGLT2, or both, seem to increase at a maximum to the patients who were having cardiovascular disease or no cardiovascular disease. There seemed to be no difference. The maximum percentage of using one or both was still only 21%. Overall, though, the use of SGLT2 inhibitors was higher than GLP-1 receptor agonists. And that may be due to injection issues, but I think really there's a lot of work to be done on the baseline therapies and the cardiovascular outcome study-driven therapies as well. So I think this is an important point to summarize. This is a large cross-sectional study with almost 10,000 diabetic patients, 13 countries with a standardized methodology. 1 in 3 adults with type 2 diabetes had established CVD. Fewer than 1 in 4 with established CVD and type 2 diabetes used the glucose-lowering agent with demonstrated cardiovascular benefits. And we need to do something about the implementation in order to put the evidence into the physician and the patient's hands and implementing the correct guidelines. So this is just the summary. A third of diabetic patients have cardiovascular disease. 9 out of 10 patients have ASCVD within the cardiovascular disease space, and only 2 out of 10 patients with diabetes are getting cardiovascular risk-lowering agents. The economic burden is something we have to mention. It's enormous. In the United States alone, it's 1.7 trillion burden of cardiometabolic disease. The burden of healthcare in the United States is increasing in the billions. This is in billions with a B, 3,000 billion by 2017. Most of the cost actually is due to complications of disease and not the cost of the drug. So this is very important. And the highest complication rate comes from hypertension and diabetes and CHD. Cancer is a minority. This is a remarkable problem. And in fact, this extra weight, the obesity metabolic syndrome, is actually attributing to all of this chronic disease cost directly and indirectly. It's almost 1/10 of the US GDP. And the cost of diabetes directly in terms of the event rates and the cost of treatment and the cost of diagnosis is really a staggering amount, and it's only going to get worse. So we need to start treating this as soon as possible, as early as possible, in a coordinated fashion. The 5 medical conditions that account for about 1/3 of the trillions of expenditure in healthcare, heart disease and diabetes, are literally in the top 3, much higher than cancer. And cardiovascular disease has indirect costs because of loss of productivity, disability as well. Now, these are associated conditions that come with metabolic syndrome, which we have to be very cognizant of in the primary setting and also in the cardiology setting. Sleep apnea, non-alcoholic fatty liver disease, CKD, heart failure, AFib, and dementia. Sleep apnea is tremendous. It is seen in 80% of patients with drug-resistant hypertension, 80% of heart failure patients, 72% of your diabetic patients have this, 50% of patients with AFib have it, and about 1/3 of all hypertensives, anginals, and coronary heart disease patients have this as well. And in fact, has a lot of economic cost, at least 1.9 billion in terms of comorbidities, accidents, and motor vehicle accidents, as you might imagine. Non-alcoholic fatty liver disease is an inflammatory condition due to the metabolic syndrome. It's the commonest cause of cirrhosis and liver disease now in the world, actually far exceeding hepatitis C. It's a modifiable risk factor. It's seen in 40 to 70% of diabetics, in 75% of obese patients, and almost 90% of patients with severe obesity. So this is a key point. You have to start looking for this in your patients with obesity and metabolic syndrome. 1/3 of diabetic patients and 1/5 of hypertensives have chronic kidney disease. The commonest cause of end-stage kidney disease requiring dialysis is number 1, diabetes, number 2, hypertension. 2 very treatable and recognizable diseases. How about the hepatorenal and cardiorenal association? Renal function worsening leads to stiff ventricle with diabetes and hypertension, worse renal function, worse heart failure. It's a positive feedback loop, which SGLT2 inhibitors seem to counteract very nicely. Liver dysfunction with inflammation, autoimmune disease, infection, congestive hepatopathy, non-alcoholic fatty liver disease also leads to insulin resistance, inflammation, and hypertension. GLP-1 receptor agonists seem to work very well in this space. What about heart failure? It's very clear that in addition to the insulin resistance and the metabolic syndrome, obesity will contribute to heart failure and preserved ejection fraction through cardiac fibrosis and stiffness, arterial fibrosis, activation of the RAS, activation of leptin, and increasing plasma volume and inflammation. And this is a linear relationship between the development of heart failure and preserved ejection fraction and body mass index. In fact, once the BMI hits 35, it's almost certain that this patient has heart failure and preserved ejection fraction. The relationship with reduced ejection fraction starts to occur when the BMI is about 35. So this is also the new kind of heart failure that everybody's going to start seeing in their clinic, and we have to diagnose early. Associated with a normal ejection fraction, a stiff ventricle with high filling pressures, aging, associated with AFib, diabetes, also results in secondary pulmonary hypertension and renal dysfunction. So all of these things we're encountering day to day in the clinic, we have to treat. Now, heart failure is also exploding. And as you see here, as patients age, the likelihood of heart failure increases above 60 to almost 7%, and more in males, and almost 12% above 80. And this is not only the sign of an aging condition, but also the fact that diabetes doubles the risk of heart failure, impaired fasting glucose and prediabetes increase the risk by about 1.5%. This is beyond the ischemic component of heart failure. So all patients with diabetes have at least stage A risk factor to develop heart failure, and some of them actually progress within 5 years of overt heart failure, and this is about 50% of diabetics. So it's really important for people seeing and treating diabetes to recognize the heart failure and treat early. What about atrial fibrillation? Atrial fibrillation is increasing again year by year. By 2030, it's going to be increasing by about 23%. Billions of dollars are being spent. This is not only due to aging, but also because of the metabolic factors that affect the left atrium. And finally, the impact on dementia. Remember that leptin, adipocytokines, insulin, and amylin all have direct effects. These are pancreatic and adipose enzymes that have direct effects on memory. And it's also predicted that dementia is increasing in the United States, not only due to age, but also because of the progression of metabolic disorders, which are all eminently preventable. So this brings me to the last slide. I think we've talked a lot about the interlock and intersection of all of these cardiac, metabolic, renal, hepatic, sleep apnea related disorders. And all of them start from this. All of them start from the metabolic syndrome, the abdominal obesity with insulin resistance, the dysglycemia, overt diabetes, the overlap with all types of cardiovascular disease, starting from hypertension, heart failure, CAD, arrhythmias, and AFib, respiratory illnesses such as sleep apnea, also the issue of stroke and dementia, production of cancer, of course, other issues like bone density and polycystic ovary syndrome. And that means that sitting right in the middle is cardiometabolic medicine, which encompasses obesity, lifestyle, as was very nicely stated by Dr. Hassanein, diabetes, hypertension and lipids, smoking, cardiac rehab, and appropriate early stage CV testing. In addition, the cardiologist can contribute to advanced heart failure, EP, and interventions. The endocrinologist, of course, can contribute tremendously to the thyroid, reproductive, and bone health, as well as type 2 diabetes in the complicated and early stages as well. And of course, internal medicine, screening, looking for GI disorders, liver disorders, and musculoskeletal disorders. And all of these have to be practiced on an organized and regular fashion by all practitioners who see all types of metabolic and cardiac diseases. And with that, I thank you very much. And we go back to our dear chairperson.
Thank you very much, Dr. Hani, for this excellent presentation as usual. And now we will move on to a combined case discussion on type 2 diabetes with undiagnosed heart failure and cardiovascular disease. So the floor is yours, Dr. Mohammed Hassanein and Dr. Hani. Please go ahead.
Thank you very much, Fathiya. Excellent presentation, Hani. So now we have a joint presentation together, myself and Dr. Hani, for a case. So let me just try to get the slide. So, okay. I think you need to stop sharing your slide. Yeah, thank you. Okay, so we're now going to share a presentation, myself and Dr. Hani, on a case that reflects our thoughts and ideas that we just presented today. I will start with a case that that comes frequently to our diabetes clinic. It's a true case. So here is a case of Ahmed, who is 46 years of age. He works as an accountant and attends your busy clinic. You need to think and put yourself into the atmosphere of I am busy. I have plenty of patients waiting to be seen. He has diabetes from 4 years earlier. He's married. He's got 4 children. The youngest is aged 2 years. He also has hypertension that was diagnosed a couple of years ago. And at the time, the decision was to start him on a statin. So his HbA1c currently is 7.8%. 4 months ago, it was 7%. So there's a jump of 0.8% over the last 4 months. Blood pressure is well controlled. LDL, considering that he does not have cardiovascular disease, is pretty well controlled. eGFR is normal. Albumin creatinine ratio is normal. His BMI is typical of a person with type 2 diabetes, 31. He does not smoke daily. He smokes when he goes out once or twice a week with his friends. He had an ECG, not now. I think his recent ECG was over 12 months. Now, his current medication is metformin, 1,500 milligrams per day, atorvastatin, 20 milligrams per night, and amlodipine, 10 milligrams per day. So let me show you again, and I want you to think, because there is a polling question coming to you now. So we need you to be interactive, please. So again, this is a 46 years old person with type 2 diabetes for 4 years, hypertension for 2 years. Overall, there is no problems apart from his glycemic control went up. And the question for all of us now, based on this discussion, this is the polling question. What is his cardiovascular risk category? Is it very high, high, moderate, or low? Please vote now.
So I think this is a very nice case, because in the middle of a busy clinic, sometimes we're not going to look at all these details and we might miss something, as you very nicely pointed out.
It's very true, Hani, and sometimes before the patient come in, you look quickly into the data and you make a quick sort of mental decision of what you need to do for this particular person, which is very unfortunate practice, but unfortunately, it happens in many circumstances. I'm not advocating that at all myself. Okay, so a quarter have voted that this is very high. 50% said that this patient is high risk. 22% said it's a moderate risk, and 2% said it's a low risk. Okay, what do you think, Hani?
So looking at this particular profile, just at first glance, the patient's a smoker. He has mild dyslipidemia. He has diabetes. So technically speaking, that doesn't really put him in a high or very high risk category. Now, diabetic patients in general are considered high risk if they have more than 10 years of diabetes. That's just alone, or if they have multiple risk factors. So let's see what
precisely what we have in the guidelines. So we've highlighted here for you guys the key points: the age of the patient, the duration of diabetes, he's got hypertension, good LDL, normal kidney function, obese, and smoker. And his ECG, to make it complete, was normal. So as Dr. Hani mentioned, to have very high, you need to have type 2 diabetes with cardiovascular disease, which he doesn't have, or target organ damage. Target organ damage is kidney problems, left ventricular hypertrophy, or moderate retinopathy. And we do not have that in our current patient. If we did, then of course we will be thinking of different types of treatment. In the absence of this, then we need to think of other processes. So this is the full picture. In the absence of target organ damage or cardiovascular disease, you look into the age of the patient, 50 years, below 50 years, or above 50 years. If you remember, our patient is below 50 years. So now we remove the above 50 years. Then they go to the second point, duration of diabetes. What is the duration of diabetes here? Is less than 10 years. So we remove this. So you end up now with a patient who's less than 50 years, less with type 2 diabetes, but with 2 or more risk factors. He's got hypertension, he's a smoker, and he's obese. So that clearly put him into the moderate risk. If you follow that process, guys, it will be dead easy and will only take you 1 minute to come to a conclusion. Cardiovascular disease or not, end organ damage or not. And then duration of diabetes plus the age of the patient. And then finally, the number of risk factors. So based on that now, which drug would you initiate for Ahmed? You have 7 options: a GLP-1 receptor agonist, an SGL2, a DP4 inhibitor, a sulfonylurea, a TZD. His metformin dose is 1,500 milligrams. Would you increase the dose? His HbA1c is 7.8, or you not choose any of this and think of something else? Vote now, please. Don't give them the answer, Hani.
Yes, they can see my screen, right?
We need as much votes as possible, guys. Please vote. Nobody knows what you're doing or what you're saying. Okay, let's see the poll. Okay, so a good proportion, 60% of you are saying we start this patient on a GLP-1 or an SGL2 inhibitor. So that is your preferred option. Only 4%, which I guess is 1 person, said none of the above. I personally would join my opinion with none of the above, based on the current information. Now, remember, we have talked about the lifestyle of our patients clearly. So now that we've established, based on the current information in a busy clinic, that this patient has poorly controlled HbA1c by 0.8%. And the question is he adhering to metformin or not? What happened to his change in lifestyle or progression of disease? We've talked a lot about the lifestyle. We've talked that this person is obese, he's a shisha smoker, and we talked about addressing everything. Now, what does the guideline say? The guideline says, here you need to see if the patient have cardiovascular disease or not. But we forget this. We forget this in the big line. I've highlighted this in red and removed the other. And comprehensive lifestyle, including weight management and physical activity. That's the ADA and ESD. Look into the Canadian guidelines, healthy behavior interventions throughout the process. Our own Emirates Society guidelines, they talk about very much lifestyle intervention and emphasis on exercise and weight loss and diet. So I would like to ask my patient about his lifestyle. And the point here is this perhaps could be a change in lifestyle. So I started to ask my patient about the eating habits and the physical activity. So I asked my patient, do you do any house activities? And the answer, no, doctor, I have a maid and I don't do any ironing. We send it to the laundry. So do you wash your own car, Ahmed? No, of course not. I take it to the car wash. It's not my prestige, or I don't have the effort to do this. So you live in a house, you have a garden. Do you do any gardening? And the answer still is no, I have professional gardeners who come to do the house for me or the garden for me. So I start to ask him about his weekend activities. Do you go to the local park, or do you cycle, or do you go to the gym or any physical activity? And the answer is no, in weekends we go out and have a nice meal. Okay, do you go shopping? Yes, we go to the local mall. So I said, bingo. what about walking from the car park to the mall? And he said, no, I do valet parking. I put my car in front of the entrance and do valet parking. And I don't walk in the mall. I sit and enjoy my shisha while my family are going shopping, and I sit, enjoy my shisha with my friends. So I asked him, what about walking? He said, yes, I used to walk to the local mosque. I pray Maghrib, Isha, and Fajr at the mosque. But now I've stopped going to the mosque. I pray at home. So I thought this is COVID related. And I said, why? He said, no, it's not COVID. It's just that I get pain in my leg when I walk. And I went to a doctor and they did an x-ray and they said, you have a calcaneal spur. And they referred me to an orthopedic surgeon who injected it with steroids. But do you know, doctor, the pain is no better. And it's getting higher. It's now pain in the calf. So I start to get a bit suspicious that this does not sound like necessarily a calcaneal spur. So what do you think you should do now that you've heard the story of Ahmed? You refer him to the orthopedic surgeon for further treatment of the calcaneal spur and start him yourself on some painkillers. You reduce his statin or change his statin because the muscle ache that he's talking about could be a side effect from his statin. You advise him that he simply is lacking physical fitness and he needs to restart his regular walks when he go to the mosque, as well as the nighttime walk after Isha prayer that he used to do with his friends. Or you would do the three, or you do none of the above. Please answer now your question. Read the question again. You've seen the story and the history, and I would like you to answer it as much as you can, please. Shall we allow 10 more seconds, Hani?
Sure. So I think this is a common problem because patients who have musculoskeletal issues often increase their sedentary factor and they never actually exhibit cardiac symptoms because they're limited by their musculoskeletal or extremity symptoms.
Okay, so a good proportion feel that we need to do all of these parameters. A sizable proportion feel that we should just encourage the patient to exercise a bit more. Am I correct? This is
34%
yeah.
lack of fitness and increased exercise.
Yeah, 34%, 39% said all of the above, and 16%, which I think one person, it looks like the same person who likes none of the above. And I like that person very much because he matches my opinion as well. I will not do that. I am suspicious that this pain is not the calcaneal spur. So I start to think with my patient about the physical activity. What type of physical activity? Now we've identified, this is the metabolic equivalent task. So what type of physical activity that exercise the heart and the lung? So sitting does very little. So desk or working as we are now all sitting is 1.5 metabolic score. Walking slowly, perhaps at home or in a mall, shopping, window shopping, is 2 metabolic equivalent. A more intense walking is 3. Housework, such as cleaning or mopping the floor, or playing tennis doubles, or sexual activity is 3 to 5.8. The vigorous type of activity is really going to the gym or playing some types of sports, and as you can see here. So my patient does not do any vigorous activity. He walks slowly and he's sexually active. So I asked him the question, do you get any chest discomfort after sexual intercourse? And the answer was, yes, lately I do. So I'm sorry I missed one slide. I examined my patient feet and I felt that the pulse was poor. So clearly in my mind, I'm sorry I missed that slide in my presentation here. So examination of the pulses of the feet elaborated absence of the peripheral pulse, as well as the fact that he gets a bit of chest discomfort. So clearly this patient now has moved from being a person with no vascular evidence to a person with potentially peripheral arterial disease based on myself feeling his pulse and unable to feel his posterior tibial, or indeed himself complaining of chest discomfort after sexual intercourse. So I will stop sharing my slides here, and I would like Hani to answer these important questions. I'm sure he will put the slide again for you. My questions to my friendly cardiologist is, what more questions? I mean, we don't ask many questions, but unfortunately, because of busy clinics, I need to know the questions I need to ask to unmask ischemic heart disease or heart failure. ECG, how frequent should I do it? Echo, should I request an echo or not? Should I start thinking of BMP and the NT-proBNP? Of course, the proper assessment of the peripheral arterial disease with ABI index in those at risk. How does the fact, I mean, our patient does not have erectile dysfunction, but if he did, would that be a marker? And of course, I work in a governmental sector. Which patient should I refer to the cardiologist? So I would like you, Hani, please, to take over and to give us, oh, you've got the slide here. Fantastic. Thank you, Hani. So here are my questions to you, and please take us through them, Hani.
Thank you, boss. So this is an outstanding set of questions. And I think in practical sense, we should try to profile the patient. This is what the ESC and the ADA and the ESD and all of the societies call risk enhancers. And some of them are history, simple questions. Some of them are very basic investigations like an ECG. Some of them are physical findings. And in fact, in terms of screening, I think at any point that the patient shows up in the healthcare system, this is what cardiometabolics means: exposing what is hidden using simple, appropriate history, physical, and basic tests. So let's go with symptoms. So common cardiac symptoms, such as shortness of breath, can be associated with CAD, an anginal equivalent, or CHF. The question to ask is reduced exercise tolerance. So as you saw with that patient, the guy can no longer walk in the mall. He's having more trouble going to the mosque. He's being limited by something in his leg, which could then be claudication, as your physical examination showed, fatigue, tiredness, increased time to recover after exercise. Those are very simple features that predispose the patient to early cardiovascular disease. Unfortunately, these are the earliest symptoms and are often missed or misinterpreted in the outpatient setting. I'm getting old, I'm obese, I'm not conditioned, I don't do exercise, I have a thyroid problem, I'm diabetic, or I'm anemic. So the question to ask, and there's a very simple way to look at this, this is actually a checklist that you can either ask the question or ask your nurse to ask the question, or even have the patient answer these questions while they're sitting outside your waiting room. All they have to do is put circles on these things. Shortness of breath with everyday activities, like Dr. Hassanian prompted the guy. What happens when you're at the mall? Well, I can't really walk because my family's going faster. Shortness of breath like that, or not able to go up one flight of stairs. Doctor, I'm a diabetic patient. I can't go up the stairs. This is very abnormal in a young patient. And this tells me that this patient has at least what's called New York Heart Association Functional Class 2. What about swelling in the ankles and feet? That's always abnormal. And oftentimes I've seen it attributed to amlodipine, and that's not correct in a high-risk patient. What about this? a persistent cough. This is what we call cardiac asthma. The patient's always coughing. Unfortunately, what's the first thing they're going to get? Instead of a cardiac medication or an assessment, they're going to get a bronchodilator. What about this now? You ask a specific question, trouble sleeping when you lie flat or interrupted sleep that can predispose either to sleep apnea or heart failure, rapid weight gain, and always feeling tired. The limited blood supply to the vasculature, from the vasculature and the heart to the lungs, to the legs and the arms. These are important symptoms. And of course, if the patient starts to circle these, have a very high index of suspicion of cardiovascular disease, CAD, or angina. Now, the other physical findings are fairly clear. Edema, JVP, tachycardia. This is the advanced heart failure. You're not going to see this in your outpatient clinic, or I hope not, but you are going to see this kind of patient wear in the emergency room. But bear in mind that if you see this phenomenon, edema, in the outpatient setting, don't misattribute it to something else. Start a workup and consider that this is a serious problem. Now, as Dr. Hassanein mentioned, there was a notation in the medical record that the ECG is normal. Let's take a closer look. Does anybody believe that this is a normal ECG? Well, let's look carefully. The patient has left axis deviation. Lead 1 is positive. Lead 2, 3, and AVF are all negative. So left axis deviation and also left ventricular hypertrophy is very likely. Even though the patient doesn't have any ST elevations or ST depressions, the presence of increased voltage and an abnormal axis is a very significant finding. And as Dr. Hassanein mentioned in the guidelines, this is evidence of what? Target organ damage. So even while these mild symptoms are giving us a clue, even while this ECG is being reported as normal, it's not. So you have to look at the raw data for yourself. Now, we mentioned erectile dysfunction, and believe it or not, in the ESC guidelines in 2016, and it still stands, assessment of CVD risk factors and CVD signs and symptoms in patients with erectile dysfunction. Erectile dysfunction is a marker of vascular and target organ damage. It's an indicator of diffuse cardiac and vascular disease, and assessment of cardiovascular disease needs to be done. So let's not ignore that. Now, the patient didn't say that. He said he has some chest pain with sexual activity. Now, what about peripheral artery disease? I think this is a shame that we don't have time to check patients' pulses, okay? And this is important because we're always tied to the computer and doing the electronic medical records. In fact, in Framingham, 20% of patients with PAD and diabetes. However, 40% of diabetics have atypical claudication symptoms that are often attributed to other medical conditions. So our unfortunate patient was referred to an orthopedist who thought it was a heel spur, when in fact, the number of patients with diabetes with intermittent claudication is 3 times more in males and 8 times more in females. Isn't that amazing? So if we don't check the pulses, if we don't ask for claudication and assume that the leg cramps are due to a bone problem or an orthopedic problem, or even due to statin intolerance, you're going to miss 40% of the clue in diabetic patients who have some kind of peripheral artery disease. Now, if you want to do it in a systematic manner, actually you can have your nurse do it. It's a very simple test, and I'm going to show you exactly how it's done. You put the blood pressure cuff on the arm, left and right, blood pressure cuff right here above the ankle. You occlude the pressure and you listen with a Doppler. It's very easy. You're literally measuring the blood pressure in the arm and the foot. And occlusion in the iliac vessels means that the pressure in the arm will be higher than the pressure in the leg. Why is this important? Because this is a bedside test that tells you right away that this patient has peripheral vascular disease and therefore automatically moves to a very high risk group. In fact, if the patient's diabetic and has peripheral artery disease, these are the patients who have the highest possible risk. Almost 40% of these patients will have a heart attack, stroke, or MI within 5 years. And if that isn't enough, the American Heart Association, American Diabetes Association, and ACC have outlined risk enhancers in diabetes, which include more than 10 years for type 2 diabetes, microalbuminuria, reduced GFR, 60 is not normal, retinopathy, neuropathy, and right here, ankle brachial index. And in the text, it's a very important, simple physical sign that immediately indicates the presence of atherosclerotic ASCVD and peripheral artery disease. So we should be doing it. And in fact, these are the normal values. This is a strongly recommended test in patients who are asymptomatic but at intermediate risk. Again, you measure the pressure in the arms and the feet. It's very easy. And less than 0.8 in non-diabetics or 0.9 in diabetics confirms the diagnosis. And if it's abnormal, it's not about the foot. 0.9 isn't going to cause gangrene, but it means the patient has diffuse polyvascular atherosclerosis with diabetes and is a very high-risk patient that needs the symphony or orchestra that Dr. Hassanein showed us, plus all of the diabetes control medications that make a difference. What else can you do? Also, if you want to get the patient's risk even better, more precisely, well, you can do a coronary calcium score. A coronary calcium score is a non-contrast CT scan. It's very fast, there's no preparation, no IV, and automatically you see these white dots here, which the computer circles and calculates and gives you the number. In patients with diabetes and or even metabolic syndrome, and a coronary calcium score of 0 and only 0, these patients have an annual cardiovascular event rate of only 0.4. On the other hand, if the score in diabetes or non-diabetes or metabolic syndrome is even 1 and going up to 99, the risk goes up almost triple, from 0.2 to 0.8 and from 0.4 to 1.5. So they now have calcium in the arteries. Not only is it telling you that this patient is a very high-risk patient, it's also very helpful to show the patient, these are your arteries, they're already hardened and calcified. What are you going to do about yourself? Can you please stop smoking? Can you please be compliant with the medication? And once the calcium score goes over 400, the risk of an annual cardiovascular event is 4 times. It's really important and it's very powerful. And in fact, in graphical terms, if you take an intermediate risk patient like the one that Dr. Hassanein showed, and you give them a calcium score above 100, look at what happens to their CVD incidence. It goes up like a rocket to almost 10% in the 5 years as well. So a positive calcium score is highly discriminatory. A negative calcium score, except in smokers, actually can reduce their risk significantly. Now, how do you use this in clinical practice? If you're not familiar with this, this is called the MESA score. So this is a calculator that you can get. It's a derivative of the ACC calculator, but it adds the scoring and adds the value. So this is our patient, okay? So this is not our patient, but this is an example. So you have a female who's 45 with a calcium score of 100, Caucasian, diabetic, non-smoker, no family history, LDL, the HDL is 31 and the total cholesterol is 160. Yes, lipid lowering, hypertension. What is the arterial age? Look at that. The 10-year risk of this patient with coronary calcium is 9. If the patient did not have the coronary calcium, it would be 4.2. So here, you would call the patient a low-risk patient. Here, they automatically become a high-risk patient, automatic reclassification. And the arterial age of this patient, who is 48 years old, female, with a calcium score of 100, is actually 73 years. They have aged literally 20 years just because of the calcium. The Framingham score would be 2%, 27% using the calcium score. It's a very powerful, very cheap, very simple, very quick test. Now, what about heart failure? We've talked about this patient having dyspnea, trouble with exertion. Now, could it be diabetic cardiomyopathy or the metabolic inflammatory cardiomyopathy? Is it ischemic? It's possible. We don't know. So let's establish the diagnosis accurately, and we can do it very easily in the outpatient clinic. Now, it is very important to recognize heart failure in diabetes. It's a very common and early complication of diabetes because heart failure, 40% of them have type 2 diabetes, and diabetes, 50% of those have heart failure. And if you have both, your prognosis is really, really bad. And in fact, I may have shown you this before, but in patients with just 5 years after the diagnosis of type 2 diabetes, almost 77% of these patients who had an echo and who apparently were asymptomatic had either diastolic, systolic, or both. The majority had some sort of heart failure by echo, even though they had no symptoms, and normal LV function. If you took patients who were more symptomatic, but were not properly diagnosed, those patients, at least a third of them had heart failure detected by echo during cardiac screening. So it's a very common complication. We need to know a little bit about it in the primary care setting. What is this condition? It is the thickening of the myocardium. It is the fibrosis of the myocardium. It is the lack of elasticity. So now it's a stiff myocardium. Instead of the E, which is long and elastic, it's shortened. And this leads to a big left atrium, increased pressures and shortness of breath with decreased elasticity. So heart failure in diabetes is not necessarily ischemia or MI. Of course, ASCVD and hypertension leads to ischemia and hypertensive cardiomyopathy, but you also have metabolic influences, glucotoxicity, lipotoxicity, fibrosis, hypertrophy, autonomic neuropathy, and RAS activation, which leads to the diabetic cardiomyopathy in the absence of coronary artery disease or even on top of coronary artery disease. So heart failure is almost inevitable. So am I saying that every diabetic patient, with or without dyspnea, has to have an echo? The answer is actually not, right? The ESC has published a very nice guideline for primary care physicians and particularly diabetologists to give us an alternative track to look for heart failure, which is almost 50% in our outpatient diabetics. Remember, if there are symptoms, reduced exercise tolerance, fatigue and reduced exercise recovery, early symptoms, ask the question, like Dr. Hassanein, when you walk, do you get tired? I don't walk. Can you go up the stairs? No, I cannot. So that's a clue, quick question that leads you into this. Now, the diagnosis of heart failure requires two things. First of all, the presence of an ejection fraction. So less than 40% is reduced ejection fraction, more than 50% is preserved ejection fraction. But in addition, you have subtle signs and symptoms that are often missed. You have elevated natriuretic peptides, and in the patient with a normal EF, LVH, left atrial enlargement, or diastolic dysfunction. So the first two steps, as you see in this guideline, are what? Symptoms and natriuretic peptides, then the echo. So since the heart failure is about 50% in the outpatient diabetic patient, NT-proBNP can be a very powerful tool to exclude or include heart failure in these patients. And we'll go through the guideline. So patients with lower limb edema, abnormal ECG, fatigue and dyspnea, think of the BNP, order it, especially if the patient has risk factors. Lower limb edema is never benign and should not be attributed to amlodipine. And if the NT-proBNP is normal, actually echo is not needed, and this patient may have coronary artery disease and may need a stress test or an ischemia evaluation. If it's elevated, follow the echo and triage appropriately. So this is the guideline. If the patient has suspected heart failure, high-risk group, history of hypertension or diabetes, history of symptoms, use of diuretics, ankle edema, of course, other physical examinations, and ECG, and look here what it says. Any abnormality, and what did we see in this patient? The patient just had left axis deviation, okay? Any abnormality in this high-risk group, proceed to BNP, NT-proBNP or BNP, whichever your hospital has. If this is less than 125, the patient doesn't have heart failure, and the symptoms may be due to ischemia, sleep apnea, or something else. If it's abnormal, get an echo, refer to the cardiologist. And this is the verbatim text from the guideline. Natriuretic peptide measurement by diabetologists and GPs in high-risk populations such as hypertensive or diabetics helps not only the diagnosis, but to initiate preventive measures such as RAS blockers and SGLT2 inhibitors and even GLP-1 receptor agonists. And this is what it is. If the patient has symptoms, some physical signs, abnormal ECG, the working diagnosis is heart failure. And then if the natriuretic peptide, as you see here, is above 125, heart failure is likely, get an echo, refer to the cardiologist. So in our patient, the NT-proBNP was 77. This basically excludes heart failure. Look at this. This cutoff point here, less than 125, heart failure is very unlikely, but follow the patient because they can develop it later on, maybe within a year. And as Dr. Hassanein mentioned, if we had checked the pulses, and Dr. Hassanein did check the pulses, the distal pulses were reduced. And if you have a distal pulse that reduced, look at the overlap of atherosclerotic coronary artery disease, peripheral artery disease, coronary artery disease, cerebrovascular disease. Patients with manifestation of one have coexistent disease in other vascular beds. So in conclusion, our patient is actually a 46-year-old accountant with type 2 diabetes, only 4 years duration. He also has hypertension. His A1C is 7.1. It increased. Blood pressure, as you see, normal kidney function and normal ESR. The ACG, as we said, is no abnormalities, but as we looked carefully, it actually had a reduced, left atrial enlargement, left ventricular hypertrophy, and left axis deviation. So what's the diagnosis? Type 2 diabetes, hypertension, positive for peripheral artery disease, positive for ischemic heart disease, as the coronary calcium score was over 100, but heart failure was negative. And therefore, careful risk recategorization after application of additional risk factors, careful history, physical exam, and focused investigations leads us to conclude this is in fact not a moderate risk, which was the first glance, but actually a patient at very high risk with diabetes, CVD, peripheral artery disease, LVH, which counts as target organ damage, and peripheral artery disease. Not moderate risk, but very high risk. So with that, I'll ask Dr. Hassani.
Thank you, Hani. This is great review. So perhaps we can stop the slide and just have a chat, me and Hani, about this point. So clearly, guys, to come to that stage of the different diagnosis became obvious not with extensive investigations. It came initially in your own clinic by looking into the history of the patient, as well as examining the areas that you need to examine. So such as, for example, the pulse of the patient. Now that we examined the pulse of the patient and we took a careful history from the patient, we found that he has symptoms of suggestive of claudication, as well as the chest discomfort after a metabolic equivalent type of activity of 3 to 5, which is not terribly high. So that led to the suspicion, and then the cascade of questions and the cascade of investigations that Dr. Hani mentioned, the important investigations of whether lab investigation or CT calcium contrast, without contrast, and the repeat ECG with a careful look rather than a quick glance. So all this becomes evident how in your own clinic with a simple tool of your own hand and your own history. So I think we're happy to stop and we take the questions and answers. Dr. Fathiya, would you like to open the session of Q&A?
Sure. Thank you very much for this excellent case, which we see in our daily practice. And I hope that the audience has enjoyed it as well. And I can see there are many questions in the box as well. And I have myself also a couple of questions. But let us start with the first question from the audience, and that's addressed to Muhammad. Can we include diabetic neuropathy found on a physical exam as a target organ damage while we are doing the risk stratification?
This is a very important question. Now, I think it's important from the point of we need to think of the patient in a holistic approach. I'm not treating my patient bit by bit. Glycemic control will affect his kidney, will affect his eyes, will affect his nerves, it will affect many of the organs. Neuropathy is not one of the target organ damage markers, as per all the cardiology and diabetes guidelines. But it's a marker of complication. And we know that we need to treat the patient overall. So it's an important point to address. It's a very painful complication for our patients. And it can get better with better glycemic control, better blood pressure control, and better lipids management according to many of the important studies.
Thank you.
You can permit me on this. If we
sure.
shouldn't assume that it's neuropathy, right? We should always do a vascular assessment because it could still very much be a vascular as well as a neuropathic symptom.
Sure. Dr. Hani, this question is to you, to extend on your comment. In a clinical practice, when should we screen for peripheral vascular disease in a diabetic patient, and what are the best methods to diagnose?
Right. So actually the guidelines are pretty clear. In intermediate and high-risk patients, such as diabetics, smokers, and patients with cardiovascular disease, screening should be conducted annually with ABI. And one of the things that one of our colleagues, Dr. Faisal Hassan, he's the head of our vascular medicine clinic, he's a cardiologist, we've actually initiated an ABI screening in Imperial Diabetes Center, and hopefully by, very soon we'll have the nurses trained in the intake pool to do it. It's a very basic test, and it really costs actually nothing, and it really totally reclassifies risk at the bedside. So it's recommended in the diabetic clinic and also in all smokers.
Can I just add an important point to this, Fathia, is that although the test is quite easy, it needs someone who is doing it frequently.
Correct.
So the recommendation specifically looks into men above the age of 50 with more than one risk factor, and it needs to be required to be done annually. Obviously, if they have higher risk levels, then it needs to be done. But the skill of doing the test, it's not should be, I will do one a day or two a day. It should be someone who is doing it frequently on a weekly basis, at least 20 to 30 cases. Otherwise, the skill will be diluted and the result of the test will be abnormal, falsely abnormal.
Okay, there's a question specifically related to this. Is there any valid way to measure an ABI using stethoscope rather than Doppler, which is not available in a PHC setting?
No, not at all. You cannot replace the Doppler with a stethoscope. And also the cost of the kit is very cheap. It's not expensive. After all, in diabetes clinics, we don't have many equipment. We don't have an endoscope, we don't have an angiogram, we don't have a dialysis machine. So to request, it needs to be part of the annual screen. And ideally, that process of screening for the feet and screening for the eyes need to be a bit more established. In a center such as Imperial College, where there is high volume, establishing some nurses who will be able to do this, I presume the volume will be high enough to establish the skill. But the kit itself is not expensive at all.
Okay, thank you. There's another question into that context as well. Can calcium score of a lower limb arteries be used, and what is the significance of that?
So this is unfortunately not validated. So the calcium score comes from a very large registry. So the MESA registry is actually where this was validated, easily about 8,000 or 9,000 patients, and they followed them for many years. So they realized that the calcium score is discriminatory. So doing it for the lower extremities is not specifically validated. And in fact, there may be a slight difference in the way the flow goes. So as you know, the pulsatile flow in the coronary arteries is diastolic predominantly. In the large leg vessels, it's mostly systolic. So I think the value is to do the calcium score in the validation cohort and apply it to the high-risk patient.
Sure, thank you. Mohammed, what is the role of the autonomic neuropathy study, such as the heart rate variability study, in a stratified cardiovascular risk?
Oh, definitely, it's important. If you start thinking of autonomic neuropathy affecting the cardiac outcome of our patient, it's very important, because autonomic dysfunction, that cardiac autonomic abnormality, is the recipe for heart failure and diabetic cardiomyopathy. Hani would probably allude on this more. So if you suspect that the patient, or you've done the test and you've seen the R2R variability is abnormal, then certainly this patient needs further investigations for diabetic cardiomyopathy.
So just to add to that, so if you can't do a 24-hour Holter, the other thing you can look at is the resting heart rate. So patients with sympathetic overdrive, which is the typical male, obese, metabolic syndrome, insulin-resistant smoker, if the resting heart rate is above 80, and this is in the European Society of Hypertension guidelines, that's a high-risk feature in and of itself, and that should prompt some risk assessment, and maybe in these patients, RAS blockade, beta blocker, heart failure assessment, and so on. So simply the resting heart rate is another critical vital sign as well.
Right. Would the strict glycemic control help to prevent or delay in cardiomyopathy fibrosis? Ahmed?
Well, strict metabolic control would help to improve many of the complications. Whether it helps with the cardiac problems or not, the data is a bit of debate. We've seen the UK PDS, the data after 10 years alluding to improvement, but some of the more aggressive glycemic control studies, such as ACCORD and ADVANCE, did not show that. So obviously the target for glycemic control depends on the age of the patient and the risk factors of the patient. So a patient with cardiac problems, we don't want to get to HbA1c of 6.5, but a young fit person, an HbA1c would be very important for many parameters. As we said, we do not dissect the treatment for the patient. Only in certain circumstances that becomes risky that we compromise to say, let's aim for a higher HbA1c.
Okay.
But also, if you look at the type of glycemic control, so I think maybe in the older studies there was a lot of use of SU and insulin. Now, if we shift to SGLT2 and GLP-1, maybe that will have an impact on the fibrotic. We don't know that for sure. There are small mechanistic studies, but I think maybe that's really where we need to.
But a point of caution, Hani, because all the cardiovascular outcome trials are not in a design similar to the ACCORD Advance and UKPDS. This is really very important because many doctors generalize. These cardiovascular outcome trials are beautiful, but they are done at a certain age and after a certain duration of diabetes, and in people with either the event or high risk. UKPDS, Advance and Accord were in people young as well as early onset of the diabetes. We have the beautiful outcome from GLP-1 and SGL2, not all of them, but whoever had positive in the high risk patient. We don't have that data at the time of diagnosis.
Sure. Hani, this question is to you. They say, it is easy to say that we have coronary calcium score in our history. Unfortunately, most of our patients does not have this test done. And is there any way to assess this? And the other part of the question, what I know is that to have more accurate risk assessment, we need to do an ApoB. And also, unfortunately, we don't have that available. This is from one of our audience.
So this is important, but what we tried to show here is there's a toolkit. There's a lot of tools that you can use in the outpatient setting, right? First of all, physical exam history, right? Number 2, ECG. Read the ECG carefully. If it says normal, assume it's not. Look at it if the patient is symptomatic. Using biomarkers such as lipid profile, advanced lipid profile, lipoprotein A, all of these are additive, right? But even this patient, his LDL was 80, right? So he's a diabetic patient. It really should be 70. And if he's a smoker, 1.4. So there's a lot of work to be done. It's all about details. Coronary calcium score is not an expensive test. Seriously, it costs in the US $113, right? It takes 2 minutes. Even if the patient's prepared to pay for it, I am not kidding. This is going to totally change the way you look at the patient. And the patient will change the way they look at themselves. Checking the pulse, looking for erectile dysfunction, looking for microalbuminuria. I mean, as a cardiologist, I didn't even know what microalbuminuria is until I started to get into this. So this is a very powerful marker of cardiovascular risk. So there's a lot of tools, and what the guidelines are recommending is that we take a careful clinical assessment rather than just looking at the EMR, slapping on another medication, and moving along. So more tools, more utilization, more effective strategies.
But perhaps the issue for all of us seniors and in societies is to make it easy for our colleagues in primary care, the generalists, by setting the facility being available and the guidelines and the protocols that will advocate a succession of investigations. So instead of jumping to one or overusing one test versus the other, is having the simple guide of diagnosis of suspected cardiac problem or heart failure and so on.
Sure. Hani, again, this question to you. Patient in whom is under query of heart failure. What is the first choice to order, NT, pro-MP, or PMP, and does not help to do this investigation at the primary care in the management of such patient?
So it's an excellent question. So both are equally effective. Remember, it depends on your hospital. Some hospitals have NT-proBNP. So the cutoff point there is 125 picograms per ml. Some hospitals have BNP. BNP there, the cutoff point is 30. This is the outpatient cutoff point. Now, most people who practice in the hospital are going to say that's a very strange number, because in an acute heart failure, pulmonary edema, the numbers are 300, 600, 900, and they're age dependent and affected by AFib. But in the outpatient setting, to say in or out, yes or no, it's a binary decision, 125 on NT-proBNP or if your hospital doesn't have that, 30 on the BNP. So this is also coupled with a clinical history, with a likelihood, with edema, with the ECG. But like I said, 50% of diabetic patients have this. And if you look carefully, you're going to find these patients, and the earlier you find, the better.
Right. Thank you. Mohammed, the question is to you. What about the use of metformin in heart failure?
Yeah, it should carry on unless it's class 3 or 4, but early stages we can carry on. Now I'm talking about the not the acute heart failure as an inpatient. During inpatients, of course, we stop oral therapy and we rely on insulin until the patient has recovered. But for a person that you diagnose in clinic, mild heart failure up to stage 2, metformin is fine to carry on with.
Thank you. Ani, what about the apolipoprotein B particle as a risk factor? As a risk factor.
So it's all good to look at the extra lipid profiling, but you know what? 70% of our patients don't even achieve the LDL goal or even the triglyceride goal. So we can focus on the basics. If the LDL is not a target, push, add, increase the statin, add ezetimibe. If the triglyceride is not a target, you can use fibrate, you can use icosapent ethyl, you can use omega-3. Finally, if those are normal and you still have a high-risk patient who's having recurrent events, this is the patient you look at lipoprotein A and ApoB, because in the end, you will lower the lipoprotein A by lowering the LDL, and you lower the ApoB by lowering the LDL and the triglyceride. So we focus on the basics, and we don't have to spend a lot of money on these special investigations, except maybe you have an FH patient or a very recurrent cardiovascular disease patient. So those maybe are better in the specialized clinic.
Right. Mohammed, do you think the risk of underestimating cardiovascular risk in diabetic patient is higher than overestimating it?
Well, this is the $100 question, $1 million question. I don't really know, but I think it's important to go through the steps, through the history, through the examination, and through the simple tools that you can do in outpatients. That will help you to quantify for the risk. Going with a systematic approach will help many of us, especially that we now have simple drugs that can help to modify the risk. But if you go back to the case, if you remember question number 2, we asked people, what would you prescribe? Now, it's not about starting an SGLT2 or a GLP-1. Having a patient diagnosed with ischemic heart disease or a peripheral arterial disease will entail a lot more of aggressive management and follow-up and monitoring than simply adding a GLP-1 or SGLT2 that might be indicated anyhow to improve the glycemic control.
Right. Thank you.
And I think we also did mention about antiplatelet therapy, for example. So if you identify PAD, you might just add aspirin, right? So there's a lot of benefit to these diagnoses. It's not just an academic proposition.
Here, one of the audience suggesting that is the polypill like metformin, hydrochlorothiazide, aspirin, and statin may be the real way of prevention from cardiovascular disease?
It could be. I mean, adherence with a combined pill is important. Nowadays, we have triple antihypertensives together in one tablet. We have dual glycemic control tablets. We have even dual lipid lowering drugs. So reducing the burden of the tablet number is important, but the far much more important is patient education, as well as us as healthcare professionals doing our proper job of assessment of our patients, rather than simply say, it's a busy clinic and I didn't have time. I come across patients who the decision is made for them before they step in the clinic.
Right, thank you. Hani, what is the best practice for frequency of doing ECG for a diabetic patient, or even any other investigation?
Sure. So I think from a strategic standpoint and a practical standpoint, an annual ECG is very reasonable in your workup, because the incidence of cardiovascular disease, premature and metabolic diseases and lipid is really high. So what's the cost of an ECG? It's about 80 or 90 dirhams. What's the value? It'll detect
That's the actual cost or the actual charge?
So I think that's what we charge the insurance. The cost probably like less than 10 dirham because of the paper.
Yeah.
So, and now we're doing electronics, so you don't even need paper. So I think the reality is that if we can find patients like this one with small ECG changes, it immediately, for almost no cost, identifies cardiovascular risk. I think it's very reasonable. And the guidelines are fairly liberal about this because the cost is low and the yield is high. What happens if it's abnormal? You have a specific protocol to work through. Now, we also have, you've mentioned this many times before, both Dr. Fataya and Dr. Hassanin, the incidence of cardiovascular disease premature in the UAE is incredibly high. The first age at which people have MI in this country are 48 years old. So they've already developed atherosclerosis for a decade before that. So I think this is a very high yield investigation. And then if you come to the next step, what other investigations are needed? Of course, looking at the kidney function, microalbumin, and looking at the LDL, as well as the A1C and blood pressure are sort of very high yield. And if you, like you said, apply this diagnostic to a large number of the population, we can really cut down a lot of the cardiovascular events, a lot of the complications.
Thank you. I think we've got another 5 minutes, and I have a couple of questions myself that I want to ask. So, Muhammad, should we address cardiovascular risk in those with pre-diabetes as we do for a diabetic patient?
This is a very, very important question. If you remember, Fataya, the data that we have collected from our hospital for the cardiovascular admissions, the HbA1c of those who are not diabetic was in the pre-diabetes range. That's one. Second, we decide diabetes or no diabetes based on a figure. It's like an exam. 50% you pass, 49% you fail. But life is not like this. It's a continuum. So it is very clear in my mind that people with pre-diabetes should be more aggressively treated in comparison with the general public. So the aspect of statin, the targets for blood pressure, the target for lipids, all of these figures, because they are going to develop diabetes sooner or later. So we might as well preempt the problem.
Sure. Hani, is male preponderance in cardiac patient is a local phenomena or it's a global?
So I think this has been recognized since the early 80s, and we know from Framingham and even the Women's Health Study that the premenopausal state is somehow protective, except in the presence of metabolic syndrome, where the insulin resistance sort of overrides this whole process. So in the UAE, I think there's a male preponderance of hospital admissions because of the way that the economy is structured. We have a lot of migrant workers who come with their, without their families. So I think that's maybe just a particular demographic. But overall, I think the vascular protection is present until a certain age of maybe ovarian estrogen loss. Unfortunately, and it was proven in the Women's Health Study, that the use of estrogen replacement alone does not decrease the risk of cardiovascular events and may in fact increase the risk of venous thromboembolism. So there's a natural history that may be initially favorable, but we have a lot of patients here who are female with familial hyperlipidemia. And I think it's a very strange population that we see in our lipid clinic. Maybe Dr. Wael, when he joins us on the next visit, can actually highlight this. It's a very odd preponderance of females with FH.
Right. Maybe now I address this question to Muhammad. In our region, women are more obese, and however, they have less cardiovascular disease. Why is that?
Yeah, I think it's how you measure obesity. The issue of the apple and the pear. So many women are in the pear type of shape, which is protective. So if you were to measure obesity based on BMI, weight and height, they will be obese. But the type of obesity, the central obesity, that men do not care too much about having central obesity. A male عنده كرش مش مشكلة, لكن for a female, they look after their figure, so it becomes, they look after themselves slightly on that aspect. That's one. Second, I've shown you in the data of Waqaya from Abu Dhabi that part of the difference is not only the central obesity, but the rate of hypertension and the rate of smoking is very much higher in men than women. So it's not just about one factor of obesity. The other factors are perhaps more of a cardiovascular risk in comparison to, if you look into the odds ratio of smoking versus obesity, smoking is far much higher. And smoking is much more prevalent in men than women.
Okay, thank you. Now I come to my last question, and this is addressed to both of you. We can start with Dr. Hani. Is the model of joint clinic better than fast-track services between both departments? Because this is the aim of our, series of the 4 programs. So I would like to have your insight on that.
So I have learned so much by sitting in Imperial Diabetes Center. I pick up the phone, I call my eminent colleagues, I have a quick question. Not only are we discussing immediately on the spot what we identified as risk, plan, medication, previous history. So this instant feedback and also the depth of in discussion simultaneously is so efficient and so helpful, and it allows the decision making to be taken on the spot. So it's a combination of fast track plus simultaneous learning. And I can tell you that a lot of the interest that I've had in cardiometabolic comes not only from this being physically located in the center amongst 30 or 40, diabetologists, but also as a patient. I mean, obviously, I can disclose that I'm a type 2 diabetic. I've been so for 10 years. And I've been under the care of brilliant diabetologists. And I think this has made a huge impact to me to learn why these things are important, how we can help our patients. So I think a combined clinic is 2 brains in one clinic with 1 patient, right? So I think that's always helpful. And I think the vast experience that diabetologists have had in managing the micro and macrovascular complications, the renal complications, complex regimens include insulin and GLP-1, and side effects. I think you cannot match this, as since the cardiologists are basically getting into this from a learning approach or from a new approach.
But Hani, to clarify, your clinic is not a joint clinic. It's you see patients within the center on your own.
So practically speaking, it is, because they send me the patient on the same day. They have a concern, they send the patient.
But you're not sitting, because we have combined clinics in Dubai, but not in cardiac
so
patients.
That would be ideal.
There is a debate on sitting together in the same room or separate rooms.
So having a discussion, I think, is the whole point, right? The physical location is probably relevant, but maybe having a detailed discussion. So I've had a discussion with maybe Dr. Osama. You know what? I want to try SGLT2 on this patient. Actually, I did, and the patient had recurrent UTI and this and this and this. Or can we add GLP-1? What do you think? No, the patient is frail and has hypoglycemia. So you start having this instant feedback, which if it's physically co-located, the patient can see both of us. But you know what I do is I put the doctor on speakerphone, and we can have this discussion, including the patient. So it's probably as good as we can get in terms of the resources. But I'm totally supportive of having a dual clinic with 2 doctors at the same time.
Thank you very much. There's one last comment from the audience, and I cannot resist, reading this up, because this is going to enlighten us as both society to look into this for the future. Our colleague here suggesting that to provide a checklist of a diabetic care at the level of PHC and a good referral system to screen specialized clinic. And we totally, agree with him. And hopefully in the coming 4 webinars, we will, the 3 remaining webinars, we will be addressing all this question. There are many questions actually in the Q&A box. Unfortunately, I cannot take all of them. Some of these questions had been addressed in our previous webinar related to the dyslipidemia as well as hypertension treatment. So I would, advise you to go back to the EDS Institute to listen to those webinars. With this, I would like to come to the conclusion. First of all, I would like to thank the audience, because we have 412 audience till now, with us, and, they bear to listen to all those questions and answer. And then I would like also to thank our 2 speakers for their excellent presentation and excellent interactive session. Thank you very much, Mohammed Hassanin. Thank you very much, Dr. Hani, for this excellent overview. And I would also urge our audience to register for the coming 3 webinars soon. we're going to have, as you can see, the data are indicated there for part 2 and part 3 and part 4. You will be receiving also notification on this, plus the other activities that the Emirates Diabetes Endocrine Society is doing. So I would encourage you all to attend that. And in order to obtain your CME, kindly fill in the survey. Thank you very much. Again, many thanks to our speaker, many thanks to our audience, and many thanks to our sponsor Novo Nordisk for their unrestricted educational grant. Thank you, and have a great night.
Thank you very much, Dr. Thea.
Thank you very much. Thank you.